Okay, so good morning or good afternoon everybody, and welcome to the CHF webinar on the MBS review. I'm Jo Root, for those of you who don't know me. I think probably most of you online would know me. I'm the policy manager of CHF, and at the moment I'm the acting CEO because Leanne's on leave. Thank you all for taking the time to join this webinar. This has been a while coming. Some of you may have participated in the consumer consultations we had in 2015 and in the consumer consultation in the middle of last year. The format for today is predominantly that Professor Bruce Robinson, who's the chair of the task force, is going to give you an update on the MBS review, and then Deb Kay, who's the chair of the consumer panel for the review, will talk about the consumer involvement in the process and how important that is and how it has worked so far and how you can participate. And then Bruce will go through the recommendations from the 6 reports that were released a couple of weeks ago. If you want to type in a question, you put it into the chat room on the screen at the bottom. You need to be aware that this is a moderated discussion, so not all the questions will appear up. We will decide whether a question or a comment on the chat room can go up or not. So if you want your comment or question to get up, keep it nice and try not to make it too long. The better question is one that actually just puts the question, or if you want to have a very brief comment on the process. Obviously, this is not the whole process. CHF will be doing a submission to the review and filling out the consultation survey, and you'll have a chance to have some input into CHF's positions later in the process. So with that, I'm going to hand over to Bruce. We're going to play musical chairs here. I'm going to hand over to Bruce, and he'll take you through the presentation, which should be on your screens.
Well, thanks, Jo, and thanks everyone for tuning into this discussion this afternoon. As Jo said, what I'm going to do first of all is talk briefly about the process that we've utilised for undertaking this review. We'll then have a few brief questions about the process. I'll hand over to Deb, who'll talk about the consumer involvement that we've had, and then we'll come back and go through each of the 6 sets of draft recommendations which are currently up for consultation. So before I begin, I would just like to acknowledge the traditional custodians of the land on which we're meeting today, and of course those people who are joining this meeting from across Australia too, to pay my respects to elders past, present and future. So the first question to answer is, why do we need a review? And the answer to that is on the slide. The MBS was introduced in 1987. It's grown significantly since then and now consists of over 5,700 items, each of which describes a discrete medical service. Of course, the MBS does not cover drugs, which are funded through the Pharmaceutical Benefit Scheme, and that's not new. There was clearly, in the eyes of many clinicians and many consumers, a very real need for us to identify any services that were on the schedule that we felt were unnecessary, outdated or unsafe. Now, a schedule such as this is only effective and efficient if the item use enables people to have safe care, high quality care, care which is fair and affordable for everyone, one which provides a health benefit to the individual and to the community, and economic benefit to the individual and to the community as well. We also want ongoing monitoring of quality assurance to be able to be delivered through the MBS. And finally, we want to be able to use MBS data for public benefit. And that's something that I think many of us feel perhaps could be done better than it has been in the past, and one of the things that we are going to focus on. Now, when we set out on this journey, the objectives of the review were defined with Minister Lee at that time, and broadly speaking, they were as follows. We wanted to try to improve the clinical value of services that was funded through the MBS that patients received. We wanted to try to improve the financial value of these MBS funded services as well. And that goes hand in many ways with enhancing their clinical value. If the cost of something stays the same but the clinical value of it increases, then it's overall a better deal. If the cost of it goes up and the clinical value either declines or stays the same, then it's not such a good deal. And we wanted to try to tackle that issue. That's where the terms high and low value care are derived from. We wanted to try to address also examples of overuse or indeed underuse of services. We know that work that the Quality and Safety Commission has done has demonstrated that whilst there may be areas of overuse of many services in Australia, there are significant areas of underuse as well. Areas where services are just not available because there is no provider or because patients don't know about them. We want also to identify misuse of services. That's misuse both from a patient point of view, but also from a provider point of view. We want to make sure that the MBS is contemporary and that it supports best practice. We don't want there to be incentives on the schedule that encourage people to do tests or to have procedures done that are not in keeping with current best clinical practice. We want to make sure that the rules are looked at very carefully again, because in many cases the rules are very confusing. And it's no surprise the first 100 pages of the schedule book actually is made up of rules, and reading through those rules is very, very difficult to understand some of them. We want to try to make sure that those rules are looked at again to enable them to be used more consistently. And early on in our consultation period, it was recognised that this review did require the ability to be able to make recommendations regarding new items that were identified through its course. And in some cases, we have the ability to make recommendations directly to the Minister, and in others, we make recommendations to MSAC about new items that we think should be on the schedule. Now, I talked about value, and again, one of the reasons that so many consumers and clinicians are putting time and effort into this exercise is that we would all like to see better clinical value derived from the use of this schedule. All too often at the moment, I think, and many clinicians believe, and I think many patients believe, the schedule is simply there as a list of fees that the Commonwealth will contribute towards the cost of a service. It's really not being used as a tool which can drive high quality clinical care. Now, of course, many items on the schedule do not have an evidence base that would meet any of the current health technology assessment requirements. And to be quite frank, many of the items will never have an evidence base that will meet those requirements. The example that I cite here is many years ago, a major study was undertaken looking at the importance of control of type 2 diabetes. This was undertaken through the NIH in the USA. The cost of doing that service was doing that review was extraordinary. So much so that most people agree that no one would ever fund that particular study now. So in 2017, as opposed to the mid-1980s when it was done, no one would step up to the plate and say, yes, we will pay for that. So in undertaking our review, we decided that we needed to prioritise some of the services and items initially. And in doing so, we utilised a number of sources of evidence to help us make that prioritisation. This included some of the MBS utilisation data, data from other entities which demonstrated health service utilisation and unexplained variation, and particularly the Atlas of Clinical Variation has been very helpful to us and quite timely to this review to have that available. And as you would all be aware, there's a second volume of that just being published. We've also used the literature, and we've gone to the literature to seek out high-level systematic reviews or clinical practice guidelines. In many cases, there's no need for us to undertake similar reviews or to develop guidelines ourselves here in Australia, because perfectly adequate reviews or guidelines exist elsewhere in the world. They may need to be nuanced to the Australian setting, but by and large, we don't need to reinvent the wheel all the time. Probably the piece of data that we use more than anything else is expert consensus. And that's why we've set up the structure to support the review around clinical committees, where we've identified experts in the areas of the item numbers under consideration. These experts are present on the clinical committees, not as representatives of any particular body, not a society or a college. They're there in their own right. We also have consumers. We have people who are not directly beneficiaries of the item numbers themselves, serving on these clinical committees to provide balance to the committee so that we end up with a well-rounded and non-biased recommendation from the clinical committees. And the task force then has to take advice from these clinical committees and ultimately, after consultation, make recommendations to government. And finally, it's up to the minister to decide how he wants to undertake or take our advice. Now, an example of us trying to improve clinical value is in colonoscopy. One of the things that was identified in the Quality and Safety Commission work was that there was a 30-fold difference in the use of colonoscopy per head of population across Australia. It was noted that more than 50% of patients have a repeat colonoscopy within 6 years. And the people looking at this, a large number of them gastroenterologists, but GPs and consumers as well, felt that there was sufficient evidence to suggest that colonoscopy in a significant number of these patients was a low-value service. It either wasn't really necessary or it could have been replaced by another test. And so they made recommendations to amend the MBS items to better align them and their funding with the current Australian, in this case, clinical practice guidelines for the use of colonoscopies. And the amendments to these clinical practice guidelines should make it quite clear which patients should undergo a diagnostic colonoscopy and which patients require ongoing surveillance, that is repeat colonoscopy, and at what intervals. So that's the first part of the presentation. I might just stop at this point and take brief questions about the process, and then I'll hand over to Joe, who will talk about consumer involvement. So a question from John Veach. What was the US study? This was the Diabetes Control and Complications trial. I think it was in the mid-80s. John, it may have been the mid-90s. It was a massive study undertaken at the NIH. There was also a United Kingdom general practitioner-based study which essentially concluded the same thing, that tight control of diabetes did improve or reduce the likelihood that a person would get complications of diabetes. Another question here regards the quality of pathology testing by GPs doesn't appear to have been covered yet. That's to a certain extent true. When will this be covered? It's in the process of being covered, both through the pathology clinical committee and also through a diagnostic medicine clinical committee that we've set up, which is a committee populated largely by people who request tests to be done, whether they be pathology tests or diagnostic imaging tests, and consumers. That committee is also looking at the issue of GP requesting of pathology and the quality of that requesting. Okay. Okay, so we might switch to Deb and we'll do a musical chairs here. Thanks, brothers.
Hello everyone, I'm very pleased to be here today to speak with you. It's the first time we've had a chance to talk in this way about the consumer panel. I too would like to acknowledge the traditional custodians of the land, seas and waters, and express my respect to elders past, present and future, and also note that the connection of Aboriginal and Torres Strait Islander people with the land, the law and language and culture is absolutely integral to health and wellbeing. I'd like to organise the webinar and disclose my interests, which I don't think are a conflict. I'm a member of the Consumers Health Forum as an individual and also chair the board of the Health Consumers Alliance in South Australia, which is a member of Consumers Health Forum. I have 4 slides, one about consumer engagement, one about the panel itself, then about the terms of reference of the panel, and finally the work the panel has done and is looking forward to doing now that we understand the review is going on for another 3 years. I won't read my slides, but where I talk about something that is on the screen and you need it on the screen, I will read it in case anyone can't see it at this time. So the first slide on consumer engagement dot points areas where consumers have been and are beginning to be more involved. So you will recall Bruce referred to the announcement of the review in April 2015 by the then Minister, who described the review as clinician-led but must be informed by and meet the needs of patients, was the word she used, and patient groups, and address patient outcomes. So from the outset, at least one consumer was appointed to the task force, and many of you will know Rebecca James, who's on the task force. She's also on that committee that Bruce mentioned, MSAC, Medical Services Advisory Committee, that assesses new applications for the MBS. There's a consumer on each of the clinical committees and on each of the working groups. And now we have a consumer panel, and we're getting more sophisticated, I think, in our public consultation. So let's have a look at the next slide, which is about the panel itself. I hope I click onto the right thing. It was wonderful that consumers were invited to be on groups right from the outset, but many of you who are listening, anticipating today, would be aware that while there's a strength in having individual consumers who give a perspective in a group, there definitely was a missed opportunity, and we weren't actually reflecting evidence-based practice and policy in this regard. Some of the opportunities that were being missed was that the consumers themselves on committees weren't linked into support. We weren't coordinating the bringing of consumer evidence and concepts of value to the processes, perhaps as well as we could. And certainly we didn't have a means of drawing together collective views of consumers and enabling that to help the process overall, give a holistic perspective. So these concerns were expressed and discussed, and CHF was a strong advocate for doing something about this. And in June last year, the department and CHF hosted a meeting which was attended by all the consumers who are currently on committees. And an outcome of that was the formation of the panel. And you can see there the members on the panel. You'll recognise many names. I'll quickly go through them. In addition to Rebecca, there's John Stubbs, Karen Carey, Adam Friedrich, Eileen Yerger, Helen Maxwell-Wright, Geraldine Robertson, Alison Marcus. I'll stop there for a second. So they were all current participants, consumer participants on committees. They all expressed interest in being on the panel, and they were all appointed. The panel then said, just as there's a consumer on every clinical committee, we'll have a clinician on our consumer committee, and Michael Besser from the task force agreed to do that. So our terms of reference very briefly are not to make all the decisions about every report. Bruce has described the process through which that happens. We have 2 main roles. One is to support the work of task force that I think is quite exciting, address systemic improvements in the MBS. So from the outset, the first thing the panel developed was a work plan with 4 main areas of activity, and we revisit that every meeting, and we will definitely be revisiting it at our next meeting when we have now been told the review will go on for 3 years, and we can confidently start to perhaps engage in some more long-term activity. So to finish up, I'll just tell you briefly about the work we've done to date and what we might be able to do in the future. The first area of work is supporting those consumers on committees. We've done an induction pack. The task force has agreed to amendments to the guidelines for clinical committees, so it points out the role of chairs And also for the Secretariat, key points when they must check that consumer input has been considered and integrated. We also developed a range of questions to assist consumers in committees and the committees themselves. Those questions, unsurprisingly, address access and equity and equitable outcomes, safety and quality and how that looks to consumers, and efficiency and efficacy. Many of you online would have read the literature about 1 in 3 of the health dollars not being used as well as it could be. Sometimes, and probably on most occasions, that's for the reasons Bruce talked about, where items are overused, underused, misused, and so on. And occasionally there's intentional misuse of the MBS, and my colleagues tell me that's called gaming, and we don't want either of those things to happen. So our questioning is aiming to interrogate those kinds of things. And I'm hoping as time goes on, we'll also get more sophisticated on our committees at looking at person-centred care and how items contribute to both the needs, values and perspectives of consumers being attended to, and also people's life goals, and some of the changes that are happening with the Commission's updated standards will relate to that. Another area of work is a model of informal support for consumers, and it's not formal mentoring, but being available to assist new people and building the skill set. The second area where we've done work is in relation to consumer tools. So you'll see those in the report so far, the table that's used and the impact statement, the consumer summary and so on. In terms of consumer and community comments, we're just beginning to be approached as a committee to look at reports that come from committees before they go to the task force. And certainly I understand that we will be looking at the consultation reports that come back from this process. Again, not to override the role of individual committees, but to try and bring it together so we don't miss the big messages, the principles that we want to drive the MBS into the future. And finally, we will be working on a number of position papers and a public consultation report. And we've already scoped some of that work. It relates to evidence, value, inclusion, and we are aiming to work with other areas of health technology assessment in the department, so their work informs us and our consumer engagement work informs them. So I'll leave it there if I may. I should, though, take this chance to thank not only CHF for today, but the task force, the committees and the Secretariat, who have at all times been open to the consumer agenda. So I think it's up to us now collectively to make it as good as it can be. Thank you. Thank you.
Okay, well, thank you, Deb. Let's move on now. I've talked about our process, the establishment of the task force, first of all, back in 2015, and our subsequent establishment of clinical committees who provide a draft report, which then goes out to public consultation. We're in a period of public consultation for the 6 reports that I'm about to address in a moment. That public consultation feedback is then considered by the task force in its final formulation of recommendations, which it sends up to government. Then it's up to government to decide how and when it wants to announce or recommend or implement those recommendations. The last part of the process is one that obviously is out of our hands. We did provide an interim report to the Minister in 2016, and at that stage we'd completed public consultation for our first tranche of reports. In 2017, just recently, the government announced that the task force had been extended. We've released a further 6 reports for public consultation. Those are the ones that are available now. There'll be 2 further rounds of public consultation anticipated, we think, at this stage, probably in mid-July and mid-August. So at that stage, have 18 reports out for consultation. This just shows you the timeline for these reports and the public consultation. The current round which is out are these ones here, round 1. The round 2 reports will be cardiac, intensive and emergency medicine, pathology and endocrinology. Pathology does not encompass all of the pathology part of the schedule. There are selected items which have been looked at. We've had, because of the enormity of the pathology, focus on the items which we think are being utilised most of all. Round 3 will be anaesthetics and oncology, and then we will have further consultations that will be staggered, where we will consider orthopedics, some further diagnostic imaging, further pathology, a review of the principles and rules. So that first 100 pages of the schedule has been looked at. Gynecology, our diagnostic medicine clinical committee, and we'll also be preparing an interim report on the work that's been done thus far on general practice and primary care. The reports that are currently open for public consultation are listed on this slide, and you can all read those, and we will go through those now in one by one. All right, the first report was for spinal surgery. This was essentially, this part of the schedule was pulled apart and put back together again. The main change has been that the approach that's being used to the spine, whether it be from the front, the back or the side, is the major determinant of which item numbers or which suite of item numbers can be used by the clinician. The idea is that patients should receive the same level of benefit for the same type of surgery. We know that there was very significant variation in the item numbers, both the numbers of item numbers and also the specific items numbers that were being used for exactly the same operation. And that was the type of variation that this group, the Spinal Clinical Committee, wanted to try to address. They've also made the rules clearer for clinicians, so as to reduce any inappropriate claiming, and particularly the claim of multiple MBS items in a single episode of care. And they also recommended removal of 3 items which were considered to be obsolete. There was a clinical committee specifically looking at diagnostic imaging with regard to pulmonary embolism and deep vein thrombosis. We relied heavily on the College of Radiology 2015 Choosing Wisely recommendations, which were designed to try to discourage practitioners from requesting duplex compression ultrasound unless there had been a high DVT assessment index score. We wanted to try to align the MBS usage with the current guidelines, which are actually guidelines of the College of Radiology, and also to encourage practitioners to read the Choosing Wisely recommendations carefully. We also found that there was some inappropriate use of ultrasound items for both acute deep vein thrombosis and chronic venous disease, and some of these were being co-claimed. And clearly that shouldn't have been the case, and so it's been spelled out quite clearly now that should not happen. And the rules in essence are being reviewed to deal with that. There's also been a recommendation in an explanatory note to help guide clinicians in the appropriate selection of the imaging test that is best to use when a person is suspected of having a pulmonary embolism. And that is so as to try to prevent people having 2 or 3 different imaging tests when really one should be done, perhaps one should be done first. And if there's really deep ongoing suspicion that that test may have missed something, should an additional imaging test be performed. Again, this is something that Choosing Wisely and the College of Radiologists have strongly supported. There was also a recommendation regarding knee imaging from the Diagnostic Imaging group. Essentially, that recommendation is that in people over the age 50, a knee MRI should only be performed or ordered by a specialist. We found that there were quite a lot of knee MRIs that were actually being performed in people who are above 50 years of age, who had quite clearly clinically had just simple osteoarthritis, and the test was really adding nothing to the patient's care. If in contrast the patient had a ski injury, and that ski injury had resulted in a significant traumatic injury to the knee, then it would be appropriate for a knee MRI to be done under those circumstances. But likewise, it was thought that it would be appropriate for the person to be seen by a specialist who could order that MRI under those circumstances if there was thought to be fairly significant disruption to the knee. We also wanted to improve the use of ultrasound and knee CT, both of which have a fairly limited place or role in the assessment of these types of knee problems. Renal medicine, a good committee. There was a concern expressed by this clinical committee that there was limited access to dialysis services in remote Australia, and there were very disparate ways in which that those dialysis services were being funded. And that it was felt that this meant that there was unevenness of care or variability in access to care, and that there ought to be a new item number developed to provide funding for the delivery of dialysis by nurses and Aboriginal and Torres Strait Islander health professionals and Aboriginal health workers in very remote areas. That is a recommendation that has gone up to government and has been very favourably received. We also felt that it was important that we align dialysis supervision with current contemporary practice. There were a range of ways in which dialysis supervision was being remunerated to the clinician, and it was felt that the best way of remunerating that was for there to be an item number for the supervision of dialysis over a fixed period of time, so that not every time that the person is seen by a clinician do they need to have a bill given to them. The next one was dermatology, allergy and immunology. A number of recommendations here. Firstly, around allergy testing. It was felt that allergy testing for more than 20 allergens at any one time was not appropriate, that was rarely necessary and really increased the risk of a false positive result from such a battery of allergy testing. The committee has suggested that the allergy testing items be restructured to encourage more appropriate allergy testing, greater transparency, and address concerns that some of these items are also being misused. There was also a very significant concern of this clinical committee that there were people who are having lesions removed without them ever being looked at histologically, and that there was the potential for some of those lesions that were being removed either by diathermy or liquid nitrogen to actually be malignant without that ever being established. And the first thing the patient would know, of course, is that they developed a metastatic deposit from removal of a tumour which was unrecognised as being malignant clinically. We were also concerned that there seemed to be a large number of people who were having more than 10 skin lesions, but not so many that were having 4 or 5 removed at any one time. And it was felt that that was likewise probably representative of low value care and potentially harmful care. And so the committee, again, made up of dermatologists, general practitioners, people who use these item numbers, really did feel that it was not appropriate. There should be an item number for removal of 10 or more lesions. There was correction to the item number for UV therapy. At the moment, it was possible for people to have very large numbers of UV treatments over a 12-month period, putting them at risk of actually solar damage to the skin. This is UV treatment for conditions such as psoriasis and vitiligo. And excessive use of these item numbers could in fact have been dangerous to people. Finally, there were some concerns about some of the laser equipment that was being used in the skin space not being adequately evaluated by the Therapeutic Goods Administration, and so there were recommendations that should be corrected as well. We were also asked by government to undertake the urgent after-hours primary care items that were being provided, and for which there had been an apparent very significant increase in the number of these that were being performed. Our goal here was to look specifically at the urgent after-hours primary care items, and the recommendation of the task force here was that access to the most highly remunerated rebate should be restricted to a general practitioner who is the patient's usual general practitioner who is attending a patient urgently after hours, and that after hours services that are not being provided by the patient's usual practitioner should be remunerated at a lower rate. This is not to say that after hours services don't have a very important role, but there has been a very significant increase in the number of these services. There has not been a corresponding decrease in the number of people attending emergency departments, which you might have expected had these services been truly urgent. And so it was felt that this was something that we ought to review very carefully, and the recommendation that came from the clinical committee. This was again a clinical committee chaired by Steve Hamilton, a former president of the AMA, and also populated by general practitioners, some of whom are people who do provide after-hours services to patients. So the recommendation there is that the higher rebate should be restricted to those general practitioners who are the patient's usual GP, who are seeing the patient urgently in the after-hours period. So that takes me to the end of our session. Unfortunately, there's a spelling mistake in that slide. Answers only does have one E in it, not two. But I'd be happy now to take questions. Yes, so a question from Petra is, do the future consultations cover allied health? The answer is yes, Petra, they will. And we will get to those probably during next year. Alison Marcus says she'd really like me to mention the transitional care recommendations in the renal report. I can't actually remember what they are, but maybe you know them, Deb?
Yes, well, I can make some comment. Okay. Unfortunately, Alison can't speak to it, although she's been a brilliant advocate in this area. And it's one of the areas also that the consumer panel can work on, and that is where a recommendation emerges that is outside the scope of the MBS review itself. And that happened in the renal committee, where the committee became aware of the critical need for services that assist in transition from childhood to adulthood. And so that has been framed, and Bruce has just looked it up so he can talk to it more clinically than I can, so that it will be directed to COAG so that actually some action happens. So Alison, I'm sorry if I haven't done it justice, but the notion that this critical area that people have tried to fix for a very long time can actually move into some action now. Yeah.
Deb has summarised that very well, and just looking here, yes, referral of this issue to COAG.
Sorry, I didn't say what COAG was.
Oh, COAG is the Council of Australian Governments. This is where the state and territory health ministers would all meet with the federal health minister to discuss issues that cross these different jurisdictions. There was concern expressed by the committee that there needs to be much better coordination of the support required for adolescents and young adolescents and young adults who are transitioning from the paediatric to the adult setting. We know that in the UK there's a dedicated service for this particular group of people, and that has a good effect on reducing the likelihood of a person's transplant being rejected. Hopefully with this recommendation we'll be able to get better coordination of this area of care. A question from Roger. So how should our input on specific topics go to Deb or to individual reps? That's really for you to do.
Neither. I think it should use the standard.
Yeah. Yes, so really the best place for feedback, Roger, is through the department's website, the MBS Review website, coordinated. We don't want pieces of feedback being lost because someone fails to forward an email. It's better that the department take responsibility for coordinating that. A question from Sally, how do consumer reps represent both the patient and public perspective?
I'm happy to answer.
Okay.
I don't need to move. Oh, there you go. This is pretty good. Consumers are always flexible. So I think the first part of the question is, yes, we must get a patient and a public perspective into the MBS review, and that it is about, as Bruce said in his introduction, health and economic benefits at the individual level and the community level. No individual consumer, no individual independent consumer can do that. And that's why the public consultation process is so important. So we've got some very experienced consumer reps, but they don't even begin to pretend that they can represent that holistic view. And there's really something else I want to say that I can't remember, but I'll come back when I do.
A question from Russell is, would deputising services or after-hour care all be denied access to higher rebates, or would some be deemed as equivalent to usual GP? The current recommendation, I think, Russell, is that unless the person who was providing the after-hours care was the patient's usual GP, they would not be able to access the higher rebates. Obviously, this is something that we will take feedback on, but that is the current recommendation. A question from Kate. Will the after-hours changes still allow for other GPs who have agreement with other GPs for after-hours cover to bill for urgent items, not medical deputising services? I think the answer to that question is still open, Kate. I'll have to take advice on that. I think the answer is that it has to be the patient's usual GP. But if the GPs have formed a cooperative and do access one another's records, then perhaps that's an area where there could be consideration given to some form of compromise. Any other questions?
I've got Joe here. I've got a couple of questions while we're waiting for some from the audience. One is, how does the MBS review relate to the work that's being done under Choosing Wisely, and also RACP's work, College of Physicians work, evolve? How do the three parts fit together?
Yes, it's a good question, and we clearly don't want to be reinventing the wheel here, Joe. We want to be utilising work that's already been done, and in fact, Choosing Wisely has done some tremendous work. And so in many cases we simply involve the people who've been doing that work from Choosing Wisely in the appropriate clinical committee, or ask them to provide the advice. It makes absolutely no sense for us to be reduplicating that work. We are aware of work that's being done by some of the colleges, but most of it is, for example, the College of Radiologists, the College of Pathologists are doing quite a lot of work to developing decision support tools which will enable people who request diagnostic tests to be better informed as they do that. So we are working with all of these colleges, and they make it generally very well known to us that they're doing work in these areas, so that we try to bring it together. Question from Paul, have there been any new MBS items? There has been a new MBS item recommended for dialysis, which I've just referred to. It hasn't actually been created yet because this is one of the ones which is out for public consultation. There has been a recommendation that there should be an increase in the rebate for some forms of spirometry to encourage better use of that. There has also been a recommendation from the obstetrics committee that there should be an item number for doing a mental health assessment in a woman in the postpartum period, so as to try to detect women who had postpartum depression.
I've got a question for Deb while we're also waiting, and that's maybe it's for you as well, Bruce. How do consumers get onto the committees? How are the consumers to be on the clinical committees and working groups chosen?
So that process with and through the department, that's fine, Bruce, people can recall my beautiful face. And there is an opportunity to self-nominate on the department's website. People put in their expression of interest with their CV and a selection process then occurs. That's
pretty much how it is. And there's been no shortage of consumers putting.
My understanding is that there's about 60 people on the register, or that whatever you want to, who've self-nominated. And my guess would be there's about 20 active people at the moment. I don't know that exactly. But those people will be working more and more closely together now over the next 10 years, which is terrific, and hopefully externally as well.
Okay. There's a question from Rod. Did the review consider MBS funding for nurses to deliver after-hours care? Rod, the answer is no. Specifically, it didn't, although it acknowledges that there are a range of people who can provide after-hours care. We were specifically asked to look at the urgent after-hours items. There are a number of other items that can be used, though, to deliver after-hours care. It was specifically the urgent one that we were asked to address. A question from Stuart. Professor Robinson identified that expert consensus was the most important factor in reaching conclusions. The report recommends preventing medical deputising services from billing urgent codes. Were any MDS doctors included in the working party? I think the answer to that question is no, but there were doctors on the working party who provide after-hours services. I think, though, they are people who provide those services having done a day's work as a general practitioner. We certainly, though, have had significant feedback from the MDSs. I've met with them at least 2 times, I think 3 times now actually, to discuss the concerns of the after-hours doctors. Yes, from Alexis, a question about access to health services being difficult in rural and remote Australia, and did we take this into consideration in our deliberations and recommendations? The answer very clearly, Alexis, is yes, we did, and that was the genesis of the item number, particularly for remote dialysis, where it was felt there was a very real gap. Much of what you're referring to will be covered by the group which is currently working on primary and general practitioner and primary care, because there are a number of issues of access to primary care that have been identified to us by people who work in rural and remote Australia. We've actually visited some of these locations and heard from these people firsthand. So this is still a work in progress. So I think this is from Russell. Is there a process for determining impact on consumers of restricting use of specific item numbers? Yes, that's a question that you might want to answer, Deb, because that's the reason for the creation of the consumer panel. Largely, we were concerned as a task force that rather than rely on the feedback from a single consumer who was participating on a clinical committee with a group of clinicians, that it was important that a group of consumers could get together and consider the recommendations vis-a-vis their impact on consumers directly. But you might want to add something.
Well, I think that's fine, stay there, please. I think that's certainly true, and the panel did have an opportunity to give some advice into the after-hours paper. I also am wondering, Russell, whether you're referring to post-market reviews. So is there any process for subsequently seeing if a change that we've made that we think is for good actually has perverted?
Yes, okay, so sorry if I misunderstood the question, I apologise, but I'll answer that bit anyhow. Yes, one of the things that we're doing as we make these recommendations is where we think there is potential for impact either on clinicians or on consumers, then we will be recommending that these items be reviewed after a certain period of time. And if, the greater the potential impact, the sooner we'll ask that it be reviewed, provided that period of review enables us to collect adequate, meaningful data to enable us to make a value judgment as to whether the there has indeed been impact. Some of the recommendations are frankly no negative feedback about them. Those things we obviously would recommend for review at a much later date, but if there is concern being expressed, then we will target that for earlier review. So Stuart says it seems strange that the After Hours Working Party would not include doctors who'd be impacted by the change. Can I provide an answer as to why I made this decision? The answer is yes, Stuart. We were very concerned that this review be seen by the public as a review in which they could have confidence, and that was one that wasn't being driven by people with vested interests. All of the people that we have tried to select for all of our clinical committees, not just the after hours one, but all of the clinical committees, have been people who we believe, and who, when we've done background checks on them, we believe will make recommendations which are in the public interest, not in their own interest. So we thought it was important that since there is so much commercial interest in this particular area, it would not be appropriate for us to have a member of an after-hours medical deputising service on the panel. You do obviously have the opportunity to provide feedback during this period of consultation, and we expect that you will provide feedback. But important that there not be any perceived or real conflict of interest. You add something, Joe?
No.
Deb, sorry.
No, that's fine. I think it reinforces too the importance of consumers individually and collectively giving really considered thought to the recommendations, and for feedback to both speculate on the positive and negative impacts for them and their communities, and the questions they would like answered to check that what we do as a community is working the way we hope. So I've been in consumer organisations and got up every morning to argue for access, and I will continue to do that. But we've also got to argue for outcomes, equitable outcomes that are what the community want, where they want it, when they want it. So I think this is our opportunity, certainly for industry reps, for clinicians and their organisations, and very importantly for consumer and community reps, to give clear analytical response so that we can make the MBS the system we want.
Okay, and finally, this is the last question. I'm told this is the last question from Paul on telehealth and telemedicine, which, as Paul says, can be an important way of providing care to people living in rural and remote areas. Was this considered or addressed in the consultation? It is being considered by the primary care group, Paul. We have met with some of the providers of these telehealth and telemedicine services, and we are well aware of the value that they can add. How you provide people access to them equitably without them becoming, again, an opportunity for people to make money rather than provide good care is something that the task force is going to have to very seriously about. Okay, so if anyone wants to provide feedback, there's our email and also the consultation website, and we look forward to receiving feedback. Thank you. Thank you for tuning in today. I'm sure Deb would like to add her thanks, and Joe is going to wrap up.
Okay, thank you to Bruce very much for making the time, and to Deb. I hope I think they've given you a really good overview of where we've got to and how we got there, and more importantly explained why the process and how they've arrived at the decisions the clinical committees have. Bruce has already given you the contact details for putting in your own submissions. I would urge all consumers, as Deb has, where you think there might be an impact on you or where you have a concern, that you should fill out the survey. You should send it in. They will all be collated, and the consumer panel will have a look, I think, at the summaries of those. And I think this is an opportunity. There's been a few questions about the after hours. Have your say, put it in. I think there are people who can be both sides to that argument. I think it's very important that we have them all. CHF will be putting in a submission and will be filling out a survey. If you want to share your thoughts about what position CHF should have on any of the reports, you can send them in to us at info@CHF, and they'll get to the person they'll get to us through that, and we'll collate those reports. This is an ongoing dialogue. I mean, these are the first set of reports. They will go up. The task force is not the final decision maker. The minister is the final decision maker, and the minister will obviously want to know what key stakeholder groups think, and particularly what consumers think. He's not going to want to go ahead with something which is going to be, you know, not what the community actually wants to see. I think the other point I'd make in closing, that I think that what Bruce has reported on from the six reports shows the value of this process, that they have identified obsolete items, low value items that shouldn't be happening to consumers because they're not best quality care. There's some safety concerns, particularly around the dermatology items, and value for money for the community and for individuals. So I think just by what we've heard for these 6 reports totally reinforces the need for the review. And I think when we've got an MBS that reflects modern medical practice and good value care, then all of us will benefit from having that. And I think that's a key finding from these reports. So that's all from us. Thank you all again, and thank you to everybody. All right. Have a nice afternoon, everyone. Goodbye. Thanks. Is it off, Bruce? Is it off? Yeah.